So today I am going to take about the skin and its appendages. Mainly we are discussing about the histological features of skin, how to identify the slides of skin. So objective of the class is, after the class, students should be able to enumerate the layers of the skin, then enumerate the histological layers of epidermis and its function. That is the actually layers. Histological layers of skin is your epidermis and dermis. So enumerate the histological. Again, epidermis is divided into, or it is having some layers. Layers of cells. So we have to know, enumerate the histological layers of epidermis and its function. Then enumerate the different types of cells of epidermis. Then enumerate the histological layers of dermis and its function, and enumerate the appendages of skin and its function, then clinical importance of skin and its appendages. So whole skin and its your appendages, it is under the heading of integumentary system. Integumentary system means, integument means outer protective covering. This is the meaning of the integument. Now skin and its appendages come under the heading of integumentary system. So skin, it is relatively flat organ and it is your body's thinnest and largest and most important organ. Okay, so whole body is covered by skin, which gives the protection, mechanical protection, UV ray protection. Then it prevents the imbibition of the or invasion of the bacteria, microorganism. Okay, and moreover, it gives the your water in our body to these water so that it cannot get evaporate. So it prevents the dehydration also. Now, what are the appendages of your skin? These are hair, nails, and glands. So there are two main layers of the skin. This outer thinner layer, or it is called strata, or layer or strata, whatever. So outer thinner layer, which is known as a epidermis, which is again composed of epithelial cells. This is your keratinized, stratified squamous epithelium. Then inner layer, so epidermis and dermis. Inner layer is dermis, which is comparatively thicker than the epidermis, which is actually vascular, and having the nerve also. So vascular connective tissue, that is called dermis. Now dermis and epidermis, there is a one junction or one demarcated area, and that demarcated area is called, or line is called, dermo-epidermal junction or dermal epidermal junction. Okay. Now below the dermis, we are having the hypodermis. So epidermis and dermis, and below the dermis, we are having the hypodermis, which is actually subcutaneous tissue. It is rich of fat and areolar tissue, and fat content varies with the state of nutrition. If the people are taking more fatty food, then ultimately hypodermis it contains more fat. Okay, so thin-built person, in case of a thin-built person, this hypodermis is having less fat. Now there are two types of skin. Here it is I am saying layers, but here it is type of skin. There are two types of skin. One is thin skin and one is thick skin. It is according to your epidermis. If it is thin skin, then epidermis will be thinner. While in case of thick skin, epidermis will be more thick, or having all the layers. There are 5 layers in the epidermis. All the 5 layers will be present in the thick skin. While in case of thin skin, all the 5 layers are not present. Only the lower 4 layers are present. I will discuss. So in case of thin skin, again, what will happen? Your dermis will be more thicker, while thick skin, dermis will be less thick. Just see the contrast. In case of thin skin, epidermis is thin, while in case of thick skin, epidermis is more thick. While in case of your thin, dermis is more thicker, or your area is more, while in case of thick skin, dermis is less thicker. Clear? So thin skin covers the most of the body surface, and while thick skin, It is found over the palms of the hands, soles of the feet, and fingertips. In case of thick skin, all the 5 layers of epidermis is present, but no hair is present in the thick skin. That is why in the palm, no hair, in the sole, no hair, fingertips, no hair. So this is our 2 type of skin. One is thin, one is thick. Here all the hair follicles are present. Here it is hair follicles are not present. This is called hair follicle. Epidermis, it is having what are the cell types in the epidermis? Already I have said epidermis and dermis. Now come to the epidermis. Now some cells, it is made up of keratinized, stratified, squamous, epithelium. That is the layers. Different layers are present in the epidermis. But in the layers, there are different cells. These are different types of cells are present. Okay, this is epidermis. This is dermis. In the epidermis, there are so many cell layers. See, so many cell layers. And these cells, there are different type of cells present in this epidermis. Now, what are those? Keratinocytes, which is the main cells of the skin. All these are keratinocytes. Okay, most of the cells are keratinocytes, and they synthesize keratin. So what is keratin? Keratin is a type fibrous protein found in hair, nails, and outer skin. Clear? So whatever the nail, then your hair, and these are nothing but these are actually keratin, tough fibrous protein, which is synthesized by keratinocytes, which is present in the epidermis. So keratinocytes, around 90% of the cells of the epidermis, it is keratinocytes. Then melanocytes. Melanocyte, it is actually for the synthesis of melanin, which is a pigment of the skin. This melanin, it is a brown pigment, gives the color of the skin. If number of melanin is more, then the color of the skin will be towards the black. If the melanocytes, number of melanocytes are less, then person will be fair complexion. Now it protects these melanocytes. Again, it is color. It gives the color of the skin, as well as it protects the deeper layers from ultraviolet ray. These are melanocytes. See, this is one melanocyte. Now, suppose here another melanocyte will be there. Now, these melanocytes are having some protoplasmic projections. Have you seen? These are protoplasmic projections. Now, these protoplasmic projections, they extend throughout the epidermis and they connect with the neighboring projection of the melanocytes. So what will happen when the UV ray will try to enter or cross the epidermis, due to these cytoplasmic projections, they actually prevent the entrance of the UV ray light. Clear? So these projections are mainly responsible, and it gives the color of the skin. Then your Merkel cells. Merkel cells are nothing but these are the sensory mechanoreceptors. Suppose if we press over the skin, then we can feel that somebody is pressing or some pressure is over my skin. So it is by means of Merkel cells. So Merkel, these are Merkels. This is your Merkel. It is also having some cytoplasmic projections. But this Merkel cell is only for your sensation. Say here, this is the sensory nerve. It carries out the sensation from the Merkel cells and it goes to the higher centers. Then Langerhans cells, which is actually phagocytic cells. It provides the defense mechanism for the body. So arises from bone marrow and migrate to the epidermis. So these Langerhans cells, actually they are coming from, they are arising from the bone marrow and migrate to the epidermis. This is our Langerhans cells. So it gives your phagocytic function. Now come to the different layers. Cells are arranging and we are giving some names to each layer of these cells. So these are cells and they are arranged, all the cells are arranging in a strata. Now there are 5 strata or 5 layers from superficial to deep. This is your stratum corneum. So stratum corneum or cornified or horny layer. Okay, stratum corneum. Then your stratum lucidum. This is your stratum. Here only this stratum corneum and stratum lucidum in the most superficial part. lucidum means your lucid means clear. So it is clear cell layer. So there will be no granules, nothing will be there. Cytoplasm is very much clear. That is why it is called stratum lucidum. Then stratum granulosum. This is the cell layer having some granules in the cytoplasm. That is why it is called granular layer. Then stratum spinosum. In the stratum spinosum, most of the cells actually, they are having some spinous process, cytoplasmic spinous process. These are these Langerhans cells. Then your melanocytes, they are having some your cytoplasmic process. So stratum spinosum. Then stratum basili. So it is the basal layer which is actually resting over the basement membrane. So this is the basal lamina or basement membrane where the cells are sitting. So over and above those epithelial cells, these are extra cells which are found in your epidermis. So most of the cells, I have said it is your keratinocytes. So these keratinocytes, these are almost all are keratinocytes. Apart from these keratinocytes, some granular cells are there. Then some your lucid layer, that is stratum lucidum, where the clear cells are present. Then your stratum spinosum. So this is your, all these cells are having some spine, that is why it is called stratum spinosum. Then stratum basili. Here your stem cells are present. These cells will give rise to new cell which will replace the upper layer. Now come to the stratum corneum. So it is the most superficial layer, considered 15 to 20 layers of dead keratinized cells. Okay. So stratum, this is our stratum corneum, where this is dead cell. These are acellular structure. It consists of 15 to 20 layers of, these are layers. These are layers. So 15 to 20 layers of dead keratinized cells. Cells having no nucleus, no cell organelles because it is a dead cell. Then cytoplasm replaced by dense keratin filament. Cytoplasm replaced by dense keratin filaments. Then cell shape, it is squamous. So these cells, though it is acellular, but size and shape is your squamous. That means it is a flat. Keratinization, it is a process of cells formed from the deeper layers filled with the keratin and pushed to the surface. So keratin means these cells. Suppose here one stem cell divide, gives the new cell, it goes up, then it goes up, and gradually they become keratinized. These cells gradually they become dead, and ultimately they reach the top layer or superficial layer, and they become keratin. Why it is called keratin? Because your cytoplasm is replaced by keratin filament. Okay. Then second layer is stratum lucidum, which is clear layer. That is consists of several layers of flat cells, but it is again dead cells. Okay, from superficial. So first layer is your stratum corneum. Second is your stratum lucidum, which is a clear layer. That is why it is called lucid. So cell boundaries are again indistinct. Then cell contains nuclear debris. That means cells are going to die. Before dying, that is our stratum lucidum. So boundaries are almost indistinct. Cell nuclear debris are present because in the corneum there is no nucleus, only keratin filaments are there. Here, the cell boundaries are not distinct. Then cell contain nuclear debris and compacted keratin. That means this keratin filaments already start forming. Then appears homogeneous and more refractile optically. As it is a homogeneous, so it is more refractile. Then it blocks the water penetration and loss. So whatever the water can imbibe, suppose if a person is inside a swimming pool, then water can go inside. But due to this stratum lucidum, ultimately water cannot go inside, and water cannot evaporate from body also. So more thicker in thick skin. So as well as the skin is more thick, so your stratum lucidum is more thick. If it is a thin skin, stratum lucidum is less thick. Then stratum granulosum, that is granular layer. It is 2 to 4 layers of flat cells again, And cytoplasm of this cell contain deep staining granules, which are known as a keratohyalin. See here, cells, these are cells, flat cells, and cells in the cytoplasm, some granules are there. That is why dot structure. These dot structures are nothing but these are granules in the cytoplasm, and these granules are known as a keratohyalin. Keratinization begins in this layer. That means your cells are first this layer, then it pushed to the second your cell, that is stratum spinosum, then it is pushed to the stratum your granulosum. In this granulosum, keratin filament starts forming. Then in this, almost it is going to complete, that is in stratum lucidum, and in the stratum corneum it is completed. Then stratum spinosum or spiny layer. Spiny means as the cytoplasmic processes are extending from the cell, that is why it is called spiny. So 8 to 10 layers of keratinocyte cells. Cells are irregular in shape and attached to one another by desmosomes. These cells are attached by desmosomes. They are interconnected. Cells are interconnected by desmosomes. Then your cytoplasm contain melanosomes and keratin filament. But numbers of keratin filament will be less. And cytoplasm contain melanosomes as well as keratin filament, and cells have cytoplasmic projection, gives spine-like appearance. That is why it is called stratum spinosum or prickle cells. Then stratum basili. This stratum basili means your basal layer. This is a single layer of columnar cells. Earlier all are your flat cells. Here it is columnar cells. And cell rests on the basal lamina, that is the deepest layer. Only mitosis takes place and cell originates from this stratum basali, then it goes migrate to the superficial layer and ultimately is set up, or it is dead, and ultimately keratin filaments are, your cytoplasm is replaced by keratin filament. So cells are attached by desmosome, that means intercellular, their attachment is by desmosomes, and the base to the cells and to the basement membrane they are by hemidesmosomes. Clear? Then here stratum germinativum or the growth layer. This stratum basali and stratum spinosum. These two layers collectively we call it is a stratum germinativum, because these layers ultimately give rise to the new cells. That is why it is called stratum germinativum or growth layer. It is also known as a Malpighian layer of the skin. So this is your epidermis. So this is the basal layer. Here is this blue part is the dermis. The pink color structure is the epidermis. So this is our keratin. This is the stratum corneum layer. So layers we have to remember: stratum corneum in the superficial part, then stratum lucidum, then stratum granulosum, then stratum spinosum, then stratum basili. So from superficial to deep, or if you go from deep to superficial, then first stratum basali give rise to the new cells, then come to the stratum spinosum. These cells are having the cytoplasmic processes. Then your stratum granulosum in the cytoplasm having the granule and starts the keratin formations. Then stratum lucidum, here will be the clear cells. There in the cytoplasm nothing is there, but keratin filament formation is more prominent. Then stratum corneum, cells, your boundary is not present, and it is cytoplasm is completely replaced by the keratin filament. Then what is called regeneration time of skin. So it is the time period required for the population of cells to become mature and reproduce. That means in the stratum basali, the cells ultimately produce the new cells. So from the basal, that means starting of the formation of the cell up to the matured formation of the new cells. That is called regeneration time. Now where you can see this regeneration time, mostly in suppose if there is a cut injury, then this cut injury become filled up by new cells. This is more prominent. Otherwise, in our intake body, we cannot see how these cells are regenerated. But when there is a cut injury, we can see within 10 days, 15 days, ultimately your cut injury get healed. So that is your new cell formation, and it is your cut injuries get replaced by the new cells. So what will happen? Cell push upward into it. That means from the basal layer it goes to the spinosum. From the spinosum it goes to the granulosum. From the granulosum it goes to the lucidum, and finally it is corneum. So become keratinized, then desquamate. So whole time from the cell formed in the basal layer, then reaches up to the corneum layer. This whole time is called regeneration time. It is approximately 35 days. So dermo-epidermal, come to the dermo-epidermal junction. This is your, in normally what happens when there is a junction, this junction are, normally it is a straight line. But here dermo-epidermal junction is not a straight line. Here you see, this is the epidermis, this is the dermis. So this is not a straight line, but it is having some convolutions. See here, some convolutions are present. Here you see, this is dermis, this is epidermis. So there are convolutions. This is not a straight line. So dermo-epidermal junction is not a straight line, but it is having some your convolution. So some dermis is elevated to the epidermis, and epidermis is again invaded into the dermis. So there are some elevation and depression. Okay, so elevations there are elevation of the dermis, then depression of the epidermis. So it contains specialized fibrous elements. That means at the junction it contains some fibrous elements, and which ultimately binds the epidermis and dermis. It acts as a partial barrier for the passage of some cells and large molecules. This dermo-epidermal junction acts as a barrier also. So this is our dermo-epidermal. This is our stratum corneum layer. Then dermis. So epidermis we have completed. Now come to the dermis. So dermis or corneum, or it is actually called true skin. So it is thicker than the epidermis, then protective function against the mechanical injury, then it acts as a storage for water and electrolytes, then contains somatic sensory receptors also, that is the nerve and nerve endings. Here you see, these are the Merkel cells. These Merkel cells are the sensory cells. So say nerve is present in the dermis. Cell is present in the epidermis, but this axon is present in your dermis. Then contains somatic sensory receptors, that is your for pain, pressure, touch, temperature. Then muscle fibers are also present in the dermis, hair follicles are present in the dermis, sweat and sebaceous gland, then blood vessels are present in the dermis. So dermis is again having two layers. One is called papillary layer, one is called reticular layer. Papillary layer is the superficial part of the dermis, and deep part of the dermis is called reticular. So papillary layer, come to the papillary layer of the dermis. It is thin than your reticular layer. So reticular layer is more thick while papillary layer is thin. See here, this is the this dot structure is the papillary layer. So it goes inside see here, this is the papillary layer. And this part is our reticular. So the reticular layer is more thick than your papillary layer. So papillary layer is comparatively thin. So it contains loose connective tissue with elastic and collagen fiber. That means in the papillary layer we are having loose connective tissue with elastic and collagen fibers. Then dermal papillae. What is called dermal papillae? So dermal papillae, these are the dermis. This dermis is get elevated and invade into the epidermis. So these are called dermal papillae. Okay. So it is the projection of the dermis into the epidermis, and it creates a distinct ridge on epidermal surface of fingers and the toes. That is your fingerprints. These fingerprints are footprints. These are produced due to your dermal papillae. This dermis, as it goes into the epidermis, then what will happen? Epidermis get elevated due to your elevation of the dermal papillae. Epidermis is also get elevated, and that is why these fingerprints are produced in the skin. Now in this epidermis, I have told that in the thick skin, what will happen? All the layers of the epidermis is present. But in thin skin, your epidermis is thin. Epidermis is thin, but dermis is thick. Okay. Now what happened? Due to this your elevation of the dermal papillae, these fingerprints, footprints are produced, which is unique for every person. That is one of the most important identification your instrument, okay, for an individual. So here you say due to these dermal papillae, these are elevations over the skin. So these are fingerprints or footprints. These elevations are there. As it goes up, there is an elevation in the epidermis. Then come to the reticular layer of the dermis. Reticular layer is thick. Already this is our reticular layer, so it is thick. That contains dense irregular connective tissue. Here it is loose connective tissue. Okay, but here it is in the reticular layer, it is dense irregular connective tissue and network of collagenous and elastic fiber. It contains skeletal and smooth muscle. Then skeletal muscle over the scalp, it helps in the scalp movement and the facial expression. Means these muscles are present in the face also. Muscles are subcutaneous. Okay, it is present over the skin. Other skeletal muscles, these are present below the skin, but here it is present in the skin, and they help in the facial expression and movement of the forehead by means of the scalp muscles. Then your erector pili muscles. These are small bundles of smooth muscle. This is erector pili muscle, which is present in the your dermis. This is the erector pili muscle, which is attached to the dermoepidermal junction, and one part is attached to the hair follicle. Now what will happen when this muscle will get contract? Your hair follicles, they are obliquely placed. Once muscle is get contracted, what will happen? Hair become erect. That is why it helps in the erection of the hair follicle. Okay, erection of the hair follicle. So causes hair to stand on the end. Then somatic sensory receptors for pain, pressure, touch and temperature all are present in this layer. So these are nerve fibers. These are your Pacinian corpuscles for pressure. Already you have got in your physiology part. Then other nerve fibers are also here. Okay. All the tactile sensation, whatever the tactile sensation, that is your Meissner's corpuscles. Okay. So all these things are present in the reticular layer of the dermis. Then dermal growth and repair. Normally what happens in case of epidermis, they get shed after the certain time. These cells are in the basal layer, then after basal layer it will reach the superficial layer and ultimately they are shed off. But here they does not shed, and they are not your regenerate like epidermis. Here rapid regeneration occurs only when there is a wound, cut injury is there, or there is a healing process of the wound healing process is going on. On those cases only dermal growth is more prominent than because epidermis, that regeneration is a continuous process. Today whatever the cell in the basal layer, after 30 days it will reach the top superficial layer in the stratum corneum. But here in the dermis, that type of regeneration is not taken place. But if there is a cut injury, then only their regeneration is more prominent, it is more fast. So dense fibrous connective tissue, how does your regeneration occurs? By the production of the dense fibrous connective tissue, which will ultimately fill the wound. Or incision. Incision means when we are giving the incision for some surgical procedure. Then injury site to become your filled up by a scar. Healing, that after healing there is a scar. Now another important thing, that is our Lanzer's cleavage line. Now what is Lanzer's cleavage line actually over the skin? That is the collagenous fibers in the dermal layer. They are actually they are placed certain pattern. They are present in a certain pattern, not haphazardly present. In different area of our body, they are present in a different pattern. See here, in case of neck region, see here, head and neck region, they are present like this way. Okay? In the anterior aspect, in the posterior aspect, they are present like this way. Again, in the facial region, in your forehead, they are present longitudinally. Again, in the arm, they are present your horizontally, almost horizontally. But in the lower part of the arm, they are vertical. They have become vertical, oblique actually, not vertical, oblique. Here again in the forearm, they become your oblique. In the palm again, somewhere it is longitudinal, somewhere it is your vertical. Now, why these lines are important? Why should we know? Suppose these are the two wounds. This is the area, inguinal region. Now, surgeon give incision this way. Okay. Now here see Lanzer's lines are in a incision is giving along the Lanzer's line. Along the Lanzer's line. Once you give the incision along the Lanzer's line, wound healing process will be more good or more faster. See here, wound heals properly. But here, the incision is along the Lanzer's line. Now here you see, incision is giving across the Lanzer's line. Across this incision. See here, it is across the Lanzer's line. Now what happened? Wound healing is not proper. So there is a gap in the wound. So during surgery, we have to know the how to give the incision, whether we should give it this way or this way. Here it is horizontal. If you give incision longitudinally, then their wound healing process will be, it is not proper. Ultimately, there may be chance of gap. Okay, so that is why we should know the Lanzer's cleavage line. Now some pigments are present over the skin. One is melanin. Already I have said it is a brown pigment which gives the color of the skin according to the number or quantity of the melanin. So melanin is produced by the melanocytes, which these melanocytes, how it is they are produced? These melanocytes convert the amino acid tyrosine to melanin with the help of tyrosinase enzyme. Already in biochemistry, you have most probably got. So majority of the melanocyte found in the stratum basal layer, and amount of melanin produced depends on genetical cause. Then sun exposure. If a person is get exposed to more to sun more, then person may become your melanin number of melanin will be more. Then age, according to age also, number of melanin will be increased. Then hormone ACTH. Okay. And there is a one condition, albinism. This is a congenital condition, in which case what will happen? Individual become white and more white actually, albino individuals. The tyrosinase enzyme is absent. This is congenital defect. Tyrosinase is absent from what, and melanin cannot be synthesized. One is vitiligo. Vitiligo is a different thing. Okay, one person, suppose person become white patch over the body, that is in the adult stage or in a children, but not since birth. That is called vitiligo. Vitiligo is a pathological condition, but albinism, it is a congenital condition. Clear? Then another pigment is carotene. Carotene is a yellow pigment which is actually mostly found in the food and can be from the food. Ultimately, it is deposited in the stratum cornea of the thick skin over the palms and the soles of the feet. So other determinants of the skin color, that is your according to the blood vessels, condition of the blood vessel. If the blood vessel constricts, suppose if a person you put the water into the cold water for half an hour, very cold water, freeze water or ice, then what will happen? Become pale. Why? Because blood vessel become constrict. So if the blood vessel constrict, then it is pale. If blood vessel dilate, when people go outside in the skin, your sun exposure, then what will happen? Skin become pink, more prominent in your fair complexion person because your dilatation of the blood vessels. Then if a poorly oxygenated hemoglobin is more than it is, your what will happen? Causes cyanosis, that is bluish color. So these are actually not permanent, these are your temporary condition. Now function of the skin, mechanical protection, then sensation, then excretion, that is our that is water, which is called your Sebaceous and your sweat gland. They produce the sweat, and that is performing the excretion function. Then endocrine by your production of the vitamin D. Then immunity, that is our Langerhans cells. then your temperature regulation by dilatation and constriction of the blood vessels. Then hair, this is one appendages of our skin, that is the hair is almost present all over the body except over the thick skin, that is palm, sole of the feet. Then again lips, lip is not thick skin but it is not present. Then nipples, then some parts of the genitalia, it is not present. So at approximately 6 months of gestation, fetus is covered with some hairs and these hairs are known as a lingo. After birth, these lingo replace, these hairs fall and another some hairs, your new hairs produces, these are called vellas. Now these vellas will remain up to the puberty. At puberty, what will happen? Vellas is get replaced by terminal hair, which is our permanent, okay, after puberty. So hair growth I will not going to discuss. Then nail. So nail is actually nothing but it is the extension of the stratum corneum and stratum lucidum. This is an extension of the stratum corneum and stratum lucidum, or you can say it is more thicker than the other part of the body. That stratum corneum and stratum lucidum become more thicker in than the other parts of the body, which is called nail. Okay, and these nails is made up of keratin, and this keratin is present mostly in the our stratum corneum layer. Then come to the glands. Most common glands present is the sweat gland. So these are sweat gland. There are two type of sweat gland. One is acrine or merocrine type of sweat gland, and one is apocrine type of sweat glands. See here, this is our acrine or merocrine, which is present in the hypodermis, because this is our epidermis, this is dermis, this is hypodermis. So it is present in the hypodermis, while apocrine type of sweat gland, it is present in the dermis, in the deep part of the dermis, that is in the reticular layer. So what will happen in this acrine type of gland? This duct will directly drain over the surface of the skin with the main duct of the your acrine or sweat gland. Whatever the secretion produces in this secretory part, so secretory part is present in the hypodermis. Now this secretion is poured, it is going through this duct and ultimately drain, or it is reaches the surface, it drain over the surface of the skin. But in case of apocrine type of gland, a secretory part is present in the deep part of the dermis, that is our reticular part. But here, this duct is open into the hair follicle. See here, it opens into the hair follicle. This is our hair follicle. And from here only it reaches the surface of the skin. So this mode of the your secretion, mode of the secretion, your that is pouring of the secretion is different. Here, in case of acrine, directly they drain over the surface of the skin through the duct. But in case of apocrine type of sweat gland, they pour their secretion into the hair follicle. From the hair follicle only it goes to the top of the surface. So your acrine type of gland mostly found in the sole of the feet and the palm. So acrine, it is your sole of the feet and palms as well as forehead. And your apocrine is mainly in the armpit, that is axilla, then areola of the breast, then pigmented skin around the anus. These are apocrine type of sweat glands. Now another gland, your sebaceous gland. This is our sebaceous gland. Now this sebaceous gland, it is present in the your dermis, in the dermis, superficial part of the dermis. That is called our papillary. Just in the papillary layer, it is present. Now what will happen? These sebaceous glands, they pour their secretion into the hair follicle. Here, apocrine type of sweat gland also pour into the hair follicle, and sebaceous gland also produce pour their secretion into the hair follicle. Then they reach the surface, okay, through the hair follicle. Now, if this duct get blocked, then what will happen ultimately? If suppose duct is get blocked, then what will happen? ultimately it will get swell up, and this swelling causes the acne, which is more prominent during puberty because of the hormonal cause. So sebaceous glands, it secrete the oil for hair and skin. Simple alveolar gland found in the dermal layer. Oil is called sebum, which lubricates the skin, and it is having antifungal property also, which kills the fungus as well as bacteria. Mostly associated with hair follicle, I have said already. Glands activated at puberty, which is stimulated by the sex hormones, and that is why accumulation of the sebum in the dark white pimple. While oxidation causes the sebum to dark and become blackhead. That is why once your sebum get oxidized, it become black. That is why dark spot after forming the pimples, it becomes your color become dark. Then ceruminous glands. Where you get this? These are nothing but these are the modified type of sweat gland. Modified type of apocrine sweat gland, which are mostly found in the external ear canal. And they produce the your secretion, which is called cerumen. And this cerumen ultimately prevents the entering of the foreign body into your deeper part of the external ear. Then skin infection. Skin infection, it is called one is called impetigo. Impetigo is nothing but these are the bacterial infection caused by either staphylococcus or streptococcus, which is most common in the young children. Then tinea. Tinea is a fungal infection actually, ringworm, then jock itch, then your jock athlete's foot. So these are fungal infection. Then warts. Warts are caused by the papilloma virus. Then your boils or furuncles. These are local staphylococcus infection, and in fact it is mostly in hair follicles are get infected and it becomes inflamed and they will pass. Okay? So students just don't go. So I will take 5 minutes. Don't go away. We have already discussed this part. Come to the left atrium directly. External features, left atrium. Okay, it is a thin wall, quadrangular chamber situated behind and left side of the right atrium. So right atrium will be your right side as well as anteriorly, just posterior to slightly posterior and left the right atrium. We are having the left atrium. It forms the greater part of the base of the heart. That is the left 2/3 of the base of the heart. Then upper anterior extended part of from the left atrium is called left auricle. Then posterior to the left atrium, what structure is present? We are having the oblique sinus of the sinus, your serous pericardium. Then fibrous pericardium, that outer to that your serous. Then finally esophagus behind your left atrium. So what are the openings in the left atrium? 4 pulmonary veins on its posterior wall. Then small openings of the vena cordis minimi or Thebesian veins. Already I have said in the last class also. Then left atrioventricular opening. That is the connection between the atrium and the ventricle. Left atrium and ventricle. That is the left atrioventricular opening. It is guarded by mitral valve, having 2 cuffs. While in the right side, it is having 3 cuffs. So this is the left atrium I have cut. When we have cut them, then we can see this is the left atrioventricular opening. This is left atrium, this is left ventricle. Okay, so these are the valve this is the interatrial septum actually. This part is get cut. So anterior to that, this is the left atrium, anterior to that we are having the right atrium. So this is our interatrial septum. Now internal features of left atrium. So interior is smooth. Here you see interior is smooth. There is nothing like our right side. In the right side anterior part is having the musculopectinity. That is why it is become rough. But here internal features in the left atrium interior is smooth. Then left auricle possesses some muscular ridges in the form of network. That is in the auricle only, not in the atrium. Anterior wall presents fossa lunata. So this is the anterior wall of the left atrium, because left atrium is here, right atrium is here. So it is the anterior wall. So in the anterior wall we can see the fossa lunata. So this is the fossa lunata, which is actually in the right atrium. It is the fossa ovalis. So fossa lunata corresponds to the fossa ovalis of the right atrium. Then come to the left ventricle. Left ventricle, it is thick wall chamber, communicates with the left atrium through the left atrioventricular opening. This is the left atrioventricular opening. Wall is more thick in the left ventricle because left ventricle will have to contract more because it will have to give the supply to the whole body through the aorta. So communicates with the left atrium through left atrioventricular opening and with the ascending aorta through the aortic orifice. So there are two connections. One connection is through the left atrium, that is through left atrioventricular opening, and one connection is through the opening of the aorta or aortic orifice. Then wall of the left ventricle 3 times thicker than the right ventricle. Already I have said. Now what are the external fissures present over the left ventricle? So it forms the apex of the heart. So this is the apex of the heart. So it forms the apex of the heart, small part of sternocostal surface. Already I have said on the anterior surface, that is the anterior interventricular sulcus. Just left to the anterior interventricular sulcus, we are having the left ventricle. So small part of the sternocostal surface and most of the left 2/3 of the diaphragmatic surface. Diaphragmatic surface, this is the diaphragmatic surface. Actually it is not diaphragmatic, this part is diaphragmatic surface. So diaphragmatic surface, around left 2/3 of the diaphragmatic surface is formed by the left ventricle. So and it forms the left border of the heart. Already I have said left border, most it is by left ventricle and small part of the left auricle. Now come to the internal fissure. So it comes as a long question also. Left ventricle, left atrium, or right atrium, right ventricle. So internal fissure, interior of the left ventricle is again divided into two parts. One is inflowing. Inflowing means blood is coming from the your left atrium to left ventricle. That is called inflowing part. So and blood is going out through the aorta, that is called outflowing part. Inflowing part is the lower part, lower large part, your rough part is. Whenever there is a inflowing, always it is rough. And they are developing from the primitive part of the heart tube, that is called primitive ventricle. Then rough, why? Due to the presence of trabeculae carni. In the right ventricle also we are having the trabeculae carni. See here, that is the lower inflowing part. Lower inflowing part, it is your trabeculae carni due to the presence of muscular ridges. These are trabeculae carni. Now outflowing part, upper part is called, small upper part is called outflowing part. Here it is outflowing part. This is our aorta is here. So this part will be outflowing part. So this upper outflowing part is smooth. Why this outflowing part is smooth? Because blood will have to go out without any friction. Okay, so outflowing part is always smooth, inflowing part is always rough. Inflowing part is rough because of the presence of the muscular ridges. So outflowing part smooth, small part it is called aortic vestibule because it going to the aorta. So it is aortic vestibule. So it gives rise to ascending aorta and develop from bulbus cordis. In case of right ventricle also same thing happened. That is inflowing part rough, which is developed from primitive ventricle, and outflowing part which is developed from the bulbus cordis. Now trabeculae carni, that is the muscular ridges of the left ventricle. In case of right ventricle, we are having ridges, bridges and edge. Here ridges, bridges and pillar. Here also three types, that is ridges, bridges and pillars. Having two large papillary muscles. But in case of right ventricle, we are having three papillary muscles, anterior, posterior, septal. Here two large papillary muscle, anterior and posterior, no septal is there. So apexes of this papillary muscle, it is apex of the papillary muscle. From there, what will happen? Some fibrous tendon like structures are arising, and these tendons are attached to your valve. That is the calves of the valve. That is called your chorda tendoni. See, in case of right ventricle, that right atrioventricular orifice is guarded by your atrioventricular valve or that is tricuspid valve. Having 3 cups, that is why your 3 papillary muscle in the your right side. But in case of left side, cups is 2. So it is bicuspid. So we are having 2 papillary muscle. Okay, you can try to remember like that way. So apexes of this papillary muscle attached to the cups of the mitral valve by means of chorda tendoni. These are fibrous tendon. So there is no moderator band. In case of right ventricle, there is a moderator band. Because of this, through moderator band, right branch of AV bundle comes to the base of the heart. So base means your base of the ventricular wall. So openings of the left ventricle, left atrioventricular orifice and aortic orifice. So come to the interventricular septum. Already you know the development of the interventricular septum, but I just try to recapitulate. There are 2 parts. One is a muscular part, one is a membranous part. Okay, muscular lower part is muscular, upper part is membranous. So muscular part, it is thick and forms the major lower part of the septum, while membranous part, it is thin, which forms the upper part of the septum. A third part of the septum, that is your atrioventricular, that is developed from the AV cushion. So located between the left ventricle and the right atrium, left ventricle and right atrium. So if this part is not developed properly, there is a connection between right atrium and left ventricle. So valves of the heart, there are 2 pairs of valves. One pair AV valve, that is atrioventricular, right and left. Then one pair of semilunar, that is our in the aorta as well as in the pulmonary trunk. Come to the conducting system of the heart. So conducting system, it is made up of specialized type of myocardial tissue. It is a muscle fiber. Muscle fibers of the heart, that is the myocardial tissue. So having capacity of production and conduction of cardiac impulses. Normally, it is conduction of the impulses and production, it is having the capacity of the nerve only. But here, these muscle fiber get specialized and they can produce and conduct the cardiac impulses from one point to the next point, that is from the atrium to the ventricle. So fibers are finer than the myocardial fibers. In case of myocardium fibers, they are more thicker than the your conducting part of the heart. So it consists of SA node, AV node. SA node, it is a pacemaker of the heart, or it is called sinoatrial node. So it is a pacemaker of the heart. It generates impulse at the rate of 70 per minute. And where it is located? It is located at the upper part of sulcus terminalis. If you can see from the exterior of the heart, without cutting the heart, then we can say that the sulcus terminalis, which is extending from the superior vena cava to the inferior vena cava, there is a groove over the right atrium, that is called sulcus terminalis. So at the upper part of the sulcus terminalis, we are having the SA node. Then AV node or atrioventricular node. It is smaller than the SA, then located on the lower and posterior part of the right atrium, above the opening of the coronary sinus. So it is just above the opening of coronary sinus. What is coronary sinus? This is the venous channel of the heart, which all the veins of the heart opens into the coronary sinus, and coronary sinus opens into the our right atrium. So it generates impulse at the rate of 60 per minute. See, between the SA and AV, there is no direct connection. Mind it. SA and AV, there is no direct connection. It produces the impulses here, then it transmitted through the muscle fiber, then it reaches the, and then again AV is producing generates the impulses, again it goes through the, from AV onwards of the conducting system, they are having direct connection. So this is our side. Here we can see the sulcus terminalis. Then at the upper part of the sulcus terminalis, we are having the SA node inside the heart, inside the right atrium, not outside the right atrium. Then this is the AV node. There is no direct connection. This is the opening of the sinus venosus. This is opening of inferior vena cava. This is opening of the sinus venosus. So just above the opening of the sinus venosus, we are having the AV node. So here there is no direct connection. But from the AV node, this is the bundle of his or atrioventricular bundle. There is a connection, direct connection. Then from here, it is the right branch, left branch. At the upper part of the interventricular septum, they will divide into 2. left branch will go to the along the left side of the left ventricle, left at interventricular septum, while right branch will come along the right side of the interventricular septum. Then it reaches the base of the ventricle in your inner aspect of the ventricle. So epibundle already I have said. So this is your left branch, left bundle. Then it divides your Purkinje fibers, and these Purkinje fibers ultimately spreading over the ventricles. So we try to go ahead with coronary vasculature or blood supply of the heart. When we say blood supply, actually there are two parts. One is arterial supply, one is venous drainage. So we have to discuss both the part. If in your question it is like you said that write down the arterial supply of the heart, then you write only about the arterial supply. If it is asked to write down the your blood supply or your vasculature or coronary circulation or your blood supply of the heart, then you have to mention both artery and venous. If only arterial supply, then you write only about the artery. So come to the arterial blood supply. This is arterial supply particularly. We will discuss first arterial supply. So heart is supplied by two coronary artery. So the artery which are supplying to the heart, it is called coronary artery. Corona, from the corona word, coronary. So coronary arteries, right and left coronary artery. And these arteries, coronary artery, they are arising from aortic sinus. Now what is aortic sinus? It is the initial portion of the ascending aorta. When the aorta arising from the left ventricle, in the initial portion or in the root part, they get dilated, and this your root part, it get dilated into three. There is a three dilatation, and these dilatations are known as a aortic sinus. Okay, so these three, out of these three, there are three dilatation I have said. Out of these three, only two coronary arteries, so one sinus is non-coronary sinus and other two are coronary sinus. So it's this right and left coronary artery, what is the function? They supply the muscles as well as the other tissues of the heart. Other tissues means mainly conducting system, whatever we have discussed, SA node, AV node, then your bundle of His, then your right branch, left branch, then Purkinje fibers. So these are also supplied by this coronary artery. Though they are inside the heart and the whole blood is inside the heart, but they cannot take directly blood supply from this pool of our blood. Okay, so their heart muscle is again, they will have to be supplied by your artery. Like in the reserve bank, what happened? In the reserve bank, they are keeping the money in the reserve bank. But they cannot take their salary directly from the account, from the reserve bank account. They will have to take their salary by means of their own account only. So like that only, by the artery only heart is get supplied. So come to the right coronary artery. So it is arising from the right aortic sinus. I have said that there are three aortic sinus at the root of the or at the starting of the initial portion of the ascending aorta. There are three dilatation, and these three dilatations are known as the aortic sinus. Out of these three aortic sinus, only from there are two coronary arteries, so they are arising from two aortic sinus. One aortic sinus is non-coronary sinus. Now, right coronary arising from the right aortic sinus of the ascending aorta, while it is smaller than the left coronary, because left side, left ventricle is more thick, so left coronary should be more thicker, more your larger size, because they will have to supply more muscle. So passes anteriorly. See, this is the right coronary artery arising from the right aortic sinus. Then it it comes out through between the auricle and the root of the aorta. Then it reaches the what is the name of this sulcus? This is our coronary sulcus. So it reaches the coronary sulcus. Then it runs downwards and slightly towards the right side. Then it reaches the inferior border. It is coming through the coronary sinus. So the coronary sulcus or atrioventricular sulcus, which separates the atrium and the ventricle. So it comes through the coronary sulcus, then it reaches the inferior border of the heart, then it goes posteriorly. It goes posteriorly means it is the junction between the base of the heart and your diaphragmatic surface, because this is our diaphragmatic surface. So it goes backwards and it traverses through the atrioventricular sulcus or coronary sulcus on the posterior aspect. Clear? See here, it goes back downwards between the right atrium and right ventricle. This is our coronary or atrioventricular sulcus or coronary sulcus. So it runs downwards through the coronary sulcus, anterior part of the coronary sulcus, then it reaches the inferior border, then it goes posteriorly. See here, it comes through this way. If we remove the inferior vena cava, then we can see this is the coronary sulcus. This is our base of the heart. This is our base of the heart. It is formed by the left atrium and the right atrium. So it runs through the posterior part of the coronary sulcus. This is whole thing is our coronary sulcus. Sulcus, mind it, not the sinus. It starts here, then it goes posterior, reaches the inferior border, then it comes through the coronary sulcus obliquely in the posterior aspect, which divides the base of the heart from the diaphragmatic surface. Then finally it reaches this part, anterior aspect, which separates the atrium, left atrium and left ventricle. So this is our left part of the coronary sulcus. So now our right coronary artery comes out, then it traverses through the coronary sulcus on the anterior aspect of the coronary sulcus, then reaches the inferior border, then it goes through the posterior part of the coronary sulcus up to this area. What is the name of this area? This is called crux of the heart. That is the meeting point of the posterior interventricular groove and coronary sulcus and interatrial sulcus. Between the left and right atrium, this is interatrial. So this is the crux of the heart. Then it gives branch in the posterior interventricular sulcus. This is called posterior interventricular artery. Mind it. Again, I have to say something here. So I will go to the slide. Okay? Can you get my point?
Yes, sir.
Okay, very good. Now here it reaches the inferior margin of the heart, turns posteriorly, reaches the diaphragmatic surface, continues in the right posterior coronary sulcus to reach the posterior interventricular groove. I have said, then terminates by anastomosing with the left coronary artery. Here it is going, and this is the branch of the left coronary is coming, and here it will get anastomos. Clear? Now, where it is during this course, it will have to supply. No? There is some meaning why it will come like this way, then it is coming here. It gives some branches. Now, what are the branches? So, during this course, several branches arises from the RCA or right coronary. One is large branch, that is called marginal branch. This, as it is before reaching the inferior border, it gives a branch along the inferior border. So, it is your marginal branch. We call it as a marginal. You have to do practice of draw diagram. So this is your marginal branch of the right coronary artery. Clear? Then your posterior interventricular branch. Just now I have said this is going to the posterior part of the coronary sulcus. Then it gives one branch in the posterior interventricular groove. So this is our posterior interventricular branch of the right coronary artery. If this posterior interventricular branch is given by the right coronary artery, then we call it is right dominance. But sometimes these branch may be arise from the left coronary artery. Okay, then we call it is left dominance. Mind it. Now your small branch, that is your nodal branch. Nodal branch means See here, when it arises in this area, when it is coming out like this way, so in this area we are having a SA node, because this is our sulcus terminalis extending from the superior vena cava to the inferior vena cava. So at the upper part of the sulcus terminalis, in the interior aspect, we are having a SA node. So it will give a branch to the SA node. Clear? Branch to the SA node. That is called nodal branch. In 60% cases. In 60% cases, SA node is supplied by the right coronary, but in 40% individual, this SA node or nodal branch is arising from the left coronary instead of right coronary. Clear? Then your right atrial. See here, these will give some branches to the right atrium, because it is passing in between the right atrium and left right ventricle. So it will have to give, no? So to the atrium. So right atrial branch. Then infundibular branch. Infundibulum. Where you get the infundibulum? That is our outflow part. In the ventricle, there is outflow part. In the right ventricle, that outflow part is called infundibular part. So it will give some branches to the part of the infundibular area of the right ventricle. Then terminal branch. When this terminal branch, it is ultimately anastomosing with the left coronary artery. Here is the anastomosis with the branch of the left coronary. Now these branches, where it will supply, very easy to remember actually, just first try to draw the diagram and do some imagination. So areas of distribution, it is right atrium. It is right atrium because your right atrial branch is there. It is nearer to the right atrium, this right coronary, so it will have to supply. So right atrium. Then ventricles. Now which part of which ventricle is supplied by the right coronary? See here, this is our right ventricle. This part is right ventricle and this part is left ventricle. This is our anterior interventricular sulcus. So this is our left ventricle. So as the right atrium, it is more nearer to the right ventricle, sorry, it is more nearer to the right coronary. So what will happen? It will supply the right ventricle. Right ventricle. Again, this is our branch of the left coronary. So left coronary is also supplying. Left coronary is also supplying and right coronary is also supplying to the right ventricle. Now which part of the right ventricle? So greater part of the right ventricle is supplied by the right coronary artery except the adjoining part of the anterior interventricular group. So this is the adjoining part. This is our anterior interventricular groove, which is traversed by the left coronary, branch of the left coronary. So this part of the right ventricle is supplied by the left coronary artery. So this part will be supplied by the left coronary and most of the part of the right ventricle is supplied by the right coronary artery except the adjoining area of the anterior interventricular sulcus, which is supplied by left coronary. So we are now confined RCA or right coronary. So right coronary is supplied to the right atrium, SA node, then your right ventricle. Most of the part of the right ventricle except the adjoining part of the anterior interventricular groove. Then small part of the left ventricle. How it will supply to the left ventricle? Because in this diagram, left ventricle is here. Okay, now go to the previous diagram. See here, right coronary artery is coming like this way in the posterior part of your coronary sulcus. Yes, now this is our right ventricle, this is our left ventricle. Now interventricular groove, this is our posterior interventricular. So our interventricular artery is here, posterior interventricular artery. So this part, adjoining part of the posterior interventricular groove is supplied by the right coronary artery. So part of the left ventricle, which is adjoining part of the posterior interventricular groove, is supplied by our right ventricle. Can you get my point or not here? If you have a book, you just open the book, then it will be easier. See here, this is the right coronary, it goes, then it traverses the posterior part of the coronary sulcus, then it gives the posterior interventricular groove, posterior interventricular artery. So this is our left ventricle. So this part of the left ventricle is supplied by our branch of the left coronary artery. So small part of the left ventricle, that is adjoining part of the posterior interventricular groove, because it is traversed by our posterior interventricular branch of right coronary artery. If it is right dominance, but if it is left dominance, then RCA will not going to supply the left ventricle at all. Normally, we are discussing about the normal condition. Normally, most of the cases it is right dominance. Now, interventricular septum. Now come to the interventricular. Now, where this interventricular septum will remain? This is from the anterior interventricular groove to the posterior interventricular groove. It will lie here transversely. No, it is lie transversely. Yes, from the anterior interventricular groove, it will go to the posterior interventricular groove. Now what will happen? Anterior part of the interventricular septum will be supplied by our left coronary, and posterior part of the interventricular septum, it will be supplied by our right coronary artery. That is why it is written interventricular septum posterior part is supplied by our right coronary artery. Posterior part, not the anterior part, because anterior part is supplied by our anterior interventricular artery, which is a branch of the left coronary, LCA, left coronary artery. Then conducting system of the heart. Which part of the conducting system of the heart is supplied by the RCA? That is, already I have said SA node in 60% cases. And whole of the conducting system of the heart is supplied by RCA, except left branch of AV bundle, which will be supplied by our left coronary artery, because it is on the left ventricle. Now come to the left coronary. Can you get my point? Up to the RCA branches, then how it is supplying. If it comes as a question, then just write down these points. No need to write so long sentence. Okay. To draw the diagram, then write these points, then areas of distribution, but that much is sufficient. No need to write long sentence, and to avoid your writing long sentence, because it will not give you good marks. Then come to the LCA, that is left coronary artery. It is larger than RCA, already I have said. Arises from left posterior aortic sinus. There are three aortic sinus. One is anterior, two is posterior. Here, right coronary arising from right aortic sinus. Well, your left one is coming from the left posterior aortic sinus. Okay, so left posterior aortic sinus, our LCA, left coronary artery arise. Now it runs forwards. So it runs forwards. See here, this is our aorta. This is our, suppose here in this area, aortic sinus. Then it comes out. Then it between the pulmonary trunk and the left atrium. Then it comes out between the pulmonary trunk and the left atrium. Then it reaches the coronary, left part of the coronary sulcus. This is our coronary sulcus between the atria and ventricle. So it traverses through the coronary sulcus, left part of the coronary sulcus. Then before reaching the left border of the heart, it divides into two. Left coronary here, it divides into two. One is circumflex branch of the left coronary artery. One is anterior interventricular branch of the left coronary artery. Now this come to the circumflex branch. This circumflex branch, it goes posteriorly. Now this circumflex, this is the branch. This goes towards, it reaches the left border, and around the left border, it winds around the left border of the heart. Then it reaches the posterior part of the coronary sulcus. This is atria, this is ventricle. So this is atrioventricular groove. So it reaches the posterior part of the coronary sulcus. Clear? Then it traverses and in the posterior part of the coronary sulcus, it get anastomosed with the terminal branch of the right coronary artery. Here, this is the anastomosis. So this is our circumflex branch of the left coronary artery, and this is our anterior interventricular artery. So this is going, then it reaches the posterior part, then it traverses through the posterior part of the coronary sulcus, then it finally ends with by anastomosing with the terminal branch of the right coronary artery. Now come to the branches of the left coronary artery. So branches, your one branch already you know, anterior interventricular artery. This is anterior interventricular, and this is our circumflex branch of the left coronary artery. Then branch to the diaphragmatic surface of the left ventricle. See here, this is this branch, then this branch will give ultimately to the diaphragmatic surface of the left ventricle. These are on the diaphragmatic surface. That is why it becomes sedated. These are prominent. This prominent one is on the anterior aspect, which is on the posterior or the inferior surface of the heart. This becomes sedated. Okay. So this is your diaphragmatic branch from the left coronary artery, diaphragmatic branch. It will ultimately supply to the left atrium. Then your left atrial branch, because it will have to supply to the left atrium, so some branch arising to the left atrium, that is called left atrial branch. Then your pulmonary, that is your to the pulmonary trunk, also it will have to supply to the pulmonary trunk, so pulmonary branch. Then terminal branch. So terminal branch ultimately anastomoses with the right coronary artery. So areas of distribution, where to it supply. So it is supplied left atrial branch, it is supplied to the left atrium. You come from the atrium, okay, atrium, then ventricle, then interventricular septum, then your conducting system. Like this way, it will be easier to remember. Otherwise, if you write haphazardly, it is more difficult to remember. So left atrium. So it is supplied by the left atrial branch. Then ventricles. Now again here ventricles. In the ventricle there is some confusion actually. So which part of the ventricle will be supplied by the right coronary, which part is supplied by the left coronary. Right part already I have said. Now come to the left ventricle. So greater part of the left ventricle except the adjoining part of the posterior interventricular groove. So this is our posterior interventricular, adjoining part of the posterior interventricular groove. This is our posterior interventricular groove where our posterior interventricular branch of the right coronary is present over the diaphragmatic surface. So this adjoining part will be supplied. This is the adjoining part of the left ventricle. This is the part of the left ventricle which is supplied by the right coronary. But otherwise, you see this left coronary artery is supplying to the whole part of the left ventricle, anteriorly as well as posteriorly. Clear? Then small part of the right ventricle. Which part of the right ventricle? Because this part, adjoining part of the anterior interventricular group, this part is supplied. This is part of our right ventricle. Clear? But this part of the right ventricle is supplied by your left coronary. So left coronary is supplying to the part of the right ventricle adjoining to the or near to the anterior interventricular groove. Clear? Then interventricular septum. So anterior part is supplied by the anterior part of the interventricular septum, it is supplied by the left coronary, while posterior part of the interventricular septum, it is supplied by the right coronary. Then conducting system of the heart, left bundle, left branch of the AV bundle is supplied by the left coronary, and sometimes in 40% cases SA node is supplied by left coronary, but in 60% cases it is by right coronary artery. Then applied part of the coronary artery. So right dominant coronary artery. What is dominance here? Okay, already I have said. Right dominant coronary artery means posterior interventricular branch. If it arises from the right coronary artery, then we call it is right dominant. Then in this case, what will happen? Right coronary artery supplies the large portion of the posterior wall of the left ventricle. Then circumflex branch of the left coronary artery is relatively small in this case because this is our circumflex branch. So this is our posterior interventricular groove. And in the posterior interventricular group, we are having the posterior interventricular branch of right coronary artery. Now, as it supplies the posterior part of the interventricular septum, so these artery, it should not be so large. So it will have to supply part of the diaphragmatic surface of the left ventricle, because part of the diaphragmatic surface of the left ventricle is supplied by the right coronary. So this part, it will become smaller. But if it is left dominant artery, in this case, what will happen? This interventricular branch is arising from the left coronary. In that case, it will have to more larger in size. Clear? Then left dominant coronary artery means posterior interventricular branch arise from an enlarged circumflex branch, which is a branch of the left coronary artery. In that case, this posterior wall of the left your left ventricle, or you can say that is the interventricular septum, it will be supplied by our left coronary artery. Then coronary arterial disease. There are so many coronary arterial diseases like erythematous scleras. Erythematous plaques will be formed in the coronary artery. Then what will happen? The blood is not flowing properly through the coronary artery. In those cases, patient can be suffered from myocardial ischemia. That is called MI. Then coronary angioplasty. In case of MI, that is if a arteries get blocked due to some pathology, then what will happen? We can open the block by doing angioplasty. That is called coronary angioplasty, as it is related to the heart blood vessel. So it is called coronary angioplasty. Then coronary artery bypass grafting. In this case, what will happen? Suppose our block we cannot open up by means of angioplasty. Then what we have to see? Should we go for bypass? Bypass means suppose this proximal part of the artery. Suppose in the artery there is a block. Now proximal to the blockage artery is normal. Distal to the artery blockage artery is normal. Then what we will do? We will just bypass that block. Then we will bring the vein from the other part of our body. Then this vein will ultimately join the proximal and distal part of the coronary artery. That is called coronary artery bypass grafting, CABG. Coronary artery bypass grafting. Mostly we are taking the saphenous vein as well as our, that is called internal thoracic vein. Student? Huh?
Yes, sir.
So can we go for venous drainage? Yes. Okay. So come to the venous drainage of the heart. Artery supply we have finished. Now venous drainage. All the arteries are accompanied by vein, but we are not giving like right coronary, left coronary vein. We are giving some extra name. Already during the external fissures, I have said small cardiac, great cardiac, middle cardiac. So according to their position, according to their size, we are giving some names. So all the veins of the heart, they drain into the coronary sinus, which directly drain into the right atrium, except anterior cardiac vein and vena cordis minimi or Sebaceous veins. So these are the two veins which are actually not open into the coronary sinus. They will directly drain into the your heart chamber. Now come to the coronary sinus. Coronary sinus may come as a short note, sometimes it may come as a long question. So you have to know, and sometimes it may come as a diagrammatic question also. So coronary sinus, it is the largest vein of the heart. So it is located in the posterior coronary sulcus. So this is our posterior coronary sulcus. So this is our coronary sinus. So it is the largest vein of the heart, then located in the posterior coronary sulcus. Its length is around 3 centimeter and ends by opening into the posterior wall of the right atrium. So it opens up into the posterior wall of the right atrium. Okay, it will go and opens up into the right atrium on the posterior aspect. Then tributaries of coronary sinus. In case of artery, we call it as a branch, but here we will call it is a tributaries. So one is great cardiac vein. So great cardiac vein begins at the apex of the heart. Then this is our posterior aspect. Okay, This is not, sorry, this is from anterior aspect we are looking, and this part is faded part. It is actually posteriorly we are. This prominent part, it is our anterior aspect. Now whatever the image you are looking, this is from anterior part, and this is our posterior part. These faded lines are posterior part. Okay, these prominent part are this is one prominent, this is one prominent, this is our anterior aspect. This is again prominent part, this is anterior. But these faded lines are posterior aspect. So we are looking from the anterior aspect. So great cardiac vein. So this is the great cardiac vein. As the veins will have to go like this way, then it will open into the coronary sinus. So it starts at the apex of the heart. Okay, near the apex of the heart at the anterior interventricular groove. Then it runs in the anterior interventricular groove along with the anterior interventricular artery. Then it goes and it reaches the coronary sulcus. Here it is the coronary sulcus. Then it winds around the left border of the heart. Then it comes to the posterior aspect of the coronary sulcus. See here, it is the coronary sulcus. So it comes along the posterior part of the coronary sulcus. Then it drains into the left end of the coronary sinus. Can you get? Great cardiac vein. Here it starts. Then it goes up. Then it goes up. Then it reaches the left part of the coronary sulcus. Then it winds around the left border of the heart. Then it traverses the posterior part of the coronary sulcus. Sulcus, I am saying sulcus. Then it opens into the left end of the coronary sinus. Sinus is the venous channel, sulcus is the groove over the heart. Clear? So it begins at the apex of the great cardiac vein, gradually enlarges to form the coronary sinus and enters into the right atrium. So this is we are looking from the posterior aspect. See here from the posterior aspect. So this is our great cardiac vein. This is the anterior aspect. This comes, then it winds around the left border of the heart. Then on the coronary sulcus, posterior part of the coronary. Then in some books it retains that it become enlarged in size to form the coronary sinus. Or in some books they write that they open into the left end of the your coronary sinus. Then it opens into the right atrium. This is our right atrium. Open into the right atrium. Then another vein, that is your middle cardiac vein. It is also known as a posterior interventricular vein. Or you can say anterior great cardiac is as it is in the anterior interventricular group or anterior interventricular vein. And middle cardiac, it is our it traverses through the posterior interventricular groove, which is in the diaphragmatic surface. See here, this is the diaphragmatic surface of the heart. This is the diaphragmatic surface of the heart. This is our left ventricle, this is our right ventricle. Now, this starts again at the inferior surface or the diaphragmatic surface. Then it runs through our posterior interventricular groove. Then it opens into the coronary sinus. This is coronary sinus. Opens into the coronary sinus at the right margin of the coronary sinus. Clear? Then your small cardiac vein. Another one is your small cardiac vein. This is our small cardiac vein. Small cardiac vein, where from it comes? It comes from the right side of the ventricle. Right side of the ventricle. Then it reaches the posterior aspect of the coronary sulcus, and it opens into the right end of the coronary sinus. This is our small cardiac vein. So it comes along with our right branch of this is the right coronary will come, right coronary artery. So it comes with the right coronary artery. So small cardiac veins, so it is right marginal vein also. So in sometimes right marginal vein may drain into it. Right marginal vein, where it is, see this is our marginal vein. Because here marginal artery is there, so it is running through your inferior, along the inferior border. This is right marginal vein. Then it goes posteriorly. This is our small cardiac vein, and ultimately this small cardiac vein open into the coronary right end of the coronary sinus. Then posterior veins of the left ventricle. Posterior veins of the left ventricle. This is our left ventricle. So this side posterior cardiac. This is the posterior cardiac. This is actually draining the left surface of the heart. Left surface of the heart particularly. So runs on the diaphragmatic surface of the left ventricle, then ends in the middle of the coronary sinus. This one. Sorry, this one. This one. This is your middle cardiac vein, already we have discussed. Then small cardiac vein, already we have discussed. Then posterior veins of left ventricle. That is your runs on the diaphragmatic surface, ends in the middle of the coronary sinus. This is our, it opens into the middle of the coronary sinus. As it is draining the your left ventricle, so it is your vein of the left ventricle. Then oblique vein of the left atrium, which is of Marcel. When it was most probably discussed during the development of heart. So it is a small vein, runs on the posterior surface of the left atrium and terminates in the left end of the coronary sinus. Okay, this diagram is not shown. So terminates in the left end of the coronary sinus and draining the left atrium mainly. Then right marginal vein, already I have said right marginal, this is right marginal vein. So it is going through the inferior, winds around the inferior border, then opens into the your right end of the coronary sinus. And sometimes this branch is draining directly into the small cardiac. Sometimes it may go individually. Okay, small cardiac may drain separate vein and right marginal may be a separate vein. Okay, so right marginal vein, it accompanies the marginal branch of the right coronary artery, either drains into the small cardiac vein or directly drain into the right atrium. This is your right marginal. Now anterior cardiac vein. Anterior cardiac, because this anterior cardiac vein and vena cordis minimi, they are not going to drain into the coronary sinus. They will directly drain into the heart chamber. So anterior cardiac vein, there are 3 to 4 in numbers, run parallel to each other on the anterior wall of the right ventricle and open directly into the right atrium through its anterior wall. So instead of opening into the coronary sinus, it will directly open into the your right atrium. Then vena cordis minimi or Sebaceous veins or smallest cardiac vein. These are numerous and present in all the 4 veins, 4 chambers, and open directly into the cavity. That means they open into the right. Some veins are present on the right atrium, they will open into the right atrium. Some veins are present over the right ventricle, left ventricle, they open directly into the left ventricle. So they are over the surface of the heart and they will drain into the corresponding your chambers of the heart instead of right atrium directly. Then lymphatics of the heart, it accompany the coronary artery. It forms 2 trunks. Then your right trunk drains into the brachiocephalic nodes and left trunk drains into the tracheobronchial group of the lymph nodes. So if something is happened on the right side of the heart, then these will ultimately your brachiocephalic group of the lymph nodes. If it is from the left side, it is going into the tracheobronchial, between the trachea and the bronchus. Nerve supply of the heart, so your autonomic, it is supplied by autonomic nervous system. So it is directly responsible for regulating the heart rate, then contraction of the heart muscles and cardiac output. Okay. So innervated by both sympathetic as well as parasympathetic component. It is by forming cardiac. They are not going to supply directly like our muscles. Muscles is supplied by a direct nerve. It is not going to supply by one nerve. It is first they will form plexus, and from the plexus a nerve will go and supply to the heart. So cardiac, they are forming the cardiac plexus and consist of superficial part, that is called superficial cardiac plexus and deep cardiac plexus. So it consists of a superficial part which is forming inferior to the this is our aortic arch. So this inferior to the aortic arch, we are having a, between this pulmonary trunk and the inferior aspect of the aortic arch, we are having a superficial cardiac plexus and a deep cardiac plexus between the aortic arch and tracheobronchial bifurcation. This is our trachea. This trachea is divided into two, that is called tracheal bifurcation, and aortic arch. This is our, in between this tracheal bifurcation and aortic arch, we are having the deep cardiac plexus. So below the aortic arch, between pulmonary trunk and aortic arch, this is superficial cardiac plexus, and between the aortic arch and the tracheal bifurcation, this is our deep cardiac plexus. Now, how this cardiac plexus is forming? So, parasympathetic nerve, it is derived from the vagus nerve, which is cardio-inhibitory. If you can stimulate the vagus nerve, overstimulate the vagus nerve, there is a cardiac stoppage. So, if you want to kill someone, you just try to stimulate the vagus nerve. That in the air, our external air canal, that is our supply, posterior wall is supplied by vagus nerve. So if somehow it is more stimulated, then what will happen? It may stop the heart. That is why, which is more common in the children. Children, what will happen? Canal is not well developed, and somehow if somebody is give a slap over the ear, and due to the overstimulation of the vagus nerve, sudden cardiac arrest may happen. Okay, that is why in children we should not pull the ear. So sympathetic nerve here to the heart derived from the fourth and fifth thoracic segments of the spinal cord. So parasympathetic component is vagus, sympathetic component is fourth and fifth thoracic segments of the spinal cord. So sympathetic is cardio-axillary and parasympathetic is cardio-inhibitory. So superficial cardiac plexus is formed by the superior cervical cardiac branch of the left sympathetic chain. When we will discuss the sympathetic trunk, then it will be more elaborately discussed. So superior cervical cardiac branch of the left sympathetic. So this is our vagus. This is our superior cervical cardiac branch of the left cervical sympathetic trunk. So it will come. Then it is forming the superficial cardiac plexus here beneath our aortic arch. So superior cervical cardiac branch of the left sympathetic chain and inferior cervical cardiac branch of the left vagus. This is our inferior cervical cardiac branch of the left vagus. These two will come. This is superior cervical cardiac branch of the left cervical sympathetic trunk, and this is our inferior cervical cardiac branch of the left vagus. These two will form the plexus. Here is the ganglion, and from the ganglion, postganglionic fibers will go and supply to the heart. Deep cardiac plexus is formed by all cardiac branches derived from all the cervical. There are three: superior, middle, and inferior cervical ganglion, and upper thoracic ganglia of the sympathetic chain. Then your cardiac branches of vagus and recurrent laryngeal nerve. This is your sympathetic component. This is cardiac. Vagus is your parasympathetic component. So sympathetic component is derived from your all the cervical, that is superior, middle, and inferior cervical ganglion of the sympathetic trunk, and upper thoracic ganglia of the sympathetic chain. Then your parasympathetic component is derived from vagus and recurrent laryngeal, which is a branch of the actually vagus. So this is our deep cardiac plexus. This is our superior cervical ganglion. From the cervical ganglion, these are coming. Okay. Then your inferior, superior, inferior. Then this is our thoracic T1. Okay. Then your vagus is here not shown. This is vagus. This is vagus. So this is vagus. So this is your left vagus. From the vagus, your branch. This is from the vagus, and this is from the recurrent. This is the branch. And from sympathetic, say superior, middle, and inferior, and T1. They will give the branch. Okay, they will give the branch to form the cardiac plexus, deep cardiac plexus. So from the deep cardiac plexus, branch will go. So these two components is a unite. You can unite, club it. I have shown here separately. This is your parasympathetic component. This is your sympathetic component. So parasympathetic component derived from the vagus and the recurrent laryngeal. This is vagus. This is recurrent laryngeal. So this is the branch. These branches are coming and contributing in the formation of the deep cardiac plexus, while sympathetic component derived from the superior, middle and inferior. Sometimes this inferior cervical ganglion fused with the T1 sympathetic ganglion, then we call it stellate ganglion. So here from here also it goes and supply to the and ultimately contributing in the formation of the deep cardiac plexus. Now come to the clinical aspect, that is cardiac pain. Now this cardiac pain, when it arises, when there is an ischemia, blood is not getting, this heart muscle is not getting the blood supply, then there is a cardiac pain. This pain sensation pass through the sympathetic fibers. Now sympathetic component, it is your, see here, from the sympathetic, this is your T1, then ultimately it will go relay with the T2, T3, T4, T5 ganglion. So sympathetic, your thoracic sympathetic ganglion via the white rami, you can understand more nicely if you read today some part of the your autonomic nervous system. You just go through, and if you cannot understand, then come to me, I can make it clear. Okay. So this thoracic spinal segment, that is the part of our autonomic nervous system. So what will happen? It will supply to the spinal cord. From the spinal cord, it will go to the higher center. Okay. Some part, only one slide remain. Okay. We have a class tomorrow from 8 to 9. So by 9:30, 8:30, if I come, then also we can finish. Okay, thank you.